Hello everyone, welcome to Radiology Case Review Series. In this video, we are going to look at images of a middle-aged patient who had history of right groin hernia. He presented to the emergency department with irreducible hernia and increasing pain. He was referred to CT examination for further characterization. CT examination was performed following administration of intravenous and oral contrast. On the CT images, as I scroll down, we can see oral contrast filling slightly dilated small bowel loop. And as I scroll down further, we can see the oral contrast abruptly stops in the region of right groin. There is no extension of oral contrast into the right groin hernia. So there is a dilated bowel loop within the right groin hernia. And if we look at the localized hernial sac, and as I show you some landmarks, the hernial sac is inferior and lateral to the pubic tubercle. And as you scroll back and forth, you can clearly see the hernial sac is compressing the femoral vein. You can see the femoral vein has almost a slit-like configuration. In contrast, compare the femoral vein configuration on the contralateral side, which has got the nice round shape, and you can clearly identify the slit-like configuration of the femoral vein due to compression of the vein by the hernial sac. On the coronal images, as I scroll back and forth, you can see abrupt cutoff of contrast at the level of the right groin hernia, and you can also see compression of the femoral vein by the hernial sac. Just to illustrate the findings, we have the hernial sac which is compressing the femoral vein, which has slit-like configuration, and normal looking femoral vein on the contralateral side. This is an article which I read during my residency, and the findings described in this research article is still relevant. To quote from the article, so when dealing with a groin hernia, we can use this following algorithm. When the hernial sac is medial to pubic tubercle, it is likely to be an inguinal hernia. If the hernial sac is located lateral to the pubic tubercle and in the setting of compression of the femoral vein, we can confidently make the diagnosis of femoral hernia with high probability. And the CT diagnosis of femoral hernia has very high reproducibility. So our patient had incarcerated femoral hernia. Patient underwent emergency surgery and repair of the femoral hernia. It is important to differentiate preoperatively inguinal hernia from femoral hernia, as femoral hernia has high risk of incarceration and obstruction, whereas inguinal hernia can be treated conservatively sometimes depending on the patient's symptomatology and size. I hope you found this case to be informative and interesting. Thanks for your attention.